Thank you, Mimi, for inviting me to talk about the art of medicine, and I can't think of a more wonderful introduction than what she just gave about the art of medicine. And what I'd like to do in the next 40, 50 minutes or so is talk about the science behind the art of medicine. When I ran the Office of Alternative Medicine, one of the things I was struck by was that everything worked. Ayurveda, Chinese medicine, herbs, supplements, love, etc. No matter what came into my office, and we had thousands and thousands of things come into the office and say, pick me, I can heal, I can cure. And so it struck me that they all had different explanations. Some said it was consciousness, some said it was energy, some said it was biochemistry, and yet they all claimed that they worked. And they worked equally well, or they worked superior to other practices in those areas. So I said, what's going on in these areas? And so I learned that pretty soon that there was something going on behind all of these practices, including conventional medicine, that was like the air we breathe. We don't notice it, and yet it is one of the most powerful, and is one of the most powerful things for healing regardless. And this was one of the reasons why all these practices said they worked. Because then when you tried to put these practices into controlled clinical trials and ferret out the specific mechanisms behind them, do placebo work, most of that working compared to the context, the placebo components, the air in which they were done, they didn't work. And in fact, we saw study after study in which we said, we found something really good, let's put it into a controlled clinical trial, only to see the effect disappear. And so I said, well, what's going on here? Everything works, and yet everything doesn't work. We need to understand this a little bit better. So when I retired from the government, I was in the Army for 24 years. I'm a family doc. And I started an institute called the Samueli Institute, named after the founders. Let's see. And said, let's focus on understanding this underlying process of healing. How does it occur? Can we understand it better mechanistically? Can we understand it better to apply it in our own practices? And what are the implications for policy? And so the Institute really focuses on what creates health, what produces a flourishing society, looking for the innovative aspects through research and education. And we work closely with individuals and individual studies. About 50 to 60% of what we do is actually with our veterans and with military, and then with whole systems to see what is the system doing in these areas that can impact performance, reduce symptoms, and enhance wellness. This led me to the concept of the placebo and the research on the placebo effect. And I hope by the end of this talk, you'll stop using that word. I think it's a very misleading word. It's confusing not only our patients, it's confusing us, it's even confusing the scientists. And if we stop using the word and start looking at what do we mean behind the word, what's actually going on underneath placebo, we'll begin to answer this dilemma of why does everything work and why does nothing work. So I'm going to call those and propose that we redefine that as meaning and context effects and ask, can we isolate these things in our own practice? I'm going to take this off because this seems to be very loud and feedback. So if you don't mind, I'll use this. Is that okay? Can people hear me? What does the science say about these areas, and can we organize this in a way that we could actually utilize this information on meaning and context, in other words, the air in which we're immersed in our day-to-day work, to actually more effectively deliver healing and prevent adverse effects, the nocebo effect, in our everyday practice, no matter what we're bringing in as the so-called therapy. So here's a range of claims that you can find in the literature from the 50s to the 90s. This is a partial list of things that have been said to be healed by the placebo. Asthma attacks, hay fever, suppression of coughs, cardiac pain, altering blood counts, alleviation of nausea, altering alertness, preventing colds. And in fact, if you go and look through the literature, you'll see it commonly said that, well, most of the treatment, the specific effect that we give, the medications, for example, they produce most of the effect that we see in healing. And placebo is about a third of this. And then the rest is sort of errors that we make, bias, regression to the mean, conditioning, other types of things. So the traditional myth is that placebo, these nonspecific effects, are a fairly small amount, but what we do, what we learn about every day on our board exams and on tests, what we study, is actually producing most of the effect. And if this is true, then we're investing the appropriate amount in studying these, right? Because we invest almost everything in that medication or that specific treatment area. Well, that myth actually came from a 1955 New England Journal article by Henry Beecher, in which he, based on erroneous data, actually said, well, about a third of what we see in medical practice is due to placebo. Other reports subsequently have shown and documented that it's closer to about 70%. And the way they did this is that they found treatments that were later demonstrated to be completely inert and delivered within the context of a normal practice, could produce about a 70% effectiveness rate across a number of conditions. A New England Journal article said, no, it's not that. It's actually very little, and they reported 0 to 5% due to placebo. Dan Moorman then came along and collected studies that I'll show you in a minute and said, you know what? You can't actually say how big it is, because I can show you in uniform studies across uniform conditions a variation between 0 and 100% in the placebo arm. The point is, we can't make generalizations about the magnitude of the placebo because it's a mythical word. The problem is that we use this concept in two completely opposite ways. One is a response from the context and the meaning of the treatment, which I think was the one that we ought to be using, in which case we want to figure out how to enhance it or prevent the negative delivery of that. The second way we use it is a response from an assumed inert pill or a treatment, in which case we need to avoid that. We don't want to be giving inert things that don't work, right? We use the same word for this, and this creates this dilemma. What I'm going to suggest is that we start reframing the concept of placebo and really talk about meaning, learning, and context responses instead of the placebo effect. Dan Moorman and I wrote an article several years ago in JAMA, in the Annals, defining this as the physiological, psychological, and clinical effects of meaning and context in treatment. Sometimes inert substances, let's call them placebos, are used to help understand aspects of this meaning and context. So they're a research tool. So let me start with a case to illustrate this. So this is a real case. This is not his real name. This is a 56-year-old man came to me with something that a few of you probably have seen, chronic low back pain. And these are the kinds of things that he had gone through and been offered or had as treatment for his back pain over a number of years. Analgesics, NSAIDs, muscle relaxants, antidepressants, injection. He was told to exercise, and he was told to not exercise, to get into bed, manipulation. And he came to me because he thought, or he knew I knew something about complementary and alternative medicine. His wife was Korean, and she said, you should do acupuncture. Now, he came to me and he said, I'm first going to get an expert's opinion, right? I'm going to go in and ask the doc if I should use this, because after all, I've done all this other stuff, and I've still got back pain. It's limiting my function. And he literally asked me, he said, Doc, should I go through this? Should I do acupuncture, or is it all just a placebo? And I thought, that's a very good question. Let me see, Mr. Raymond, for a minute, and I'll find out. So I put on my evidence-based hat, and I looked through the literature, and I said, well, let's look at all these treatments that he's been under, and let's determine If, number one, they're better than placebo. Number two, are they better than no treatment? Because after all, if they're not better than no treatment, I should just tell them not to do anything. Are they better or equal to a proven treatment? I don't want to substitute it for something that works. And what are the adverse effects and costs? And these are the four questions that really, as practitioners, we need to answer for any treatment that we provide in these areas. So when I looked at Mr. Raymond, and I looked at the current evidence, and I had to generate this evidence chart, but you can now find them online. And we asked these four questions. So here's all the treatments down the vertical column that he either had or he wanted to have, and then the answer from the current state of the evidence of those questions. Green means yes, they've all been demonstrated. Red means no, it's been shown that it doesn't work. Yellow is possibly, and white is unknown. There's a lot of white things in there, as it frequently is in evidence. But you'll notice that there's only one treatment that actually answers yes to all those questions. Better than placebo, better than no treatment, equal or better than other treatment, and that's non-steroidal anti-inflammatory drugs. Unfortunately, he had atrial fibrillation, was on Coumadin at the time, could not take non-steroidal anti-inflammatory drugs. Now, if you look down at the bottom, the evidence at the time from acupuncture showed that it was better, that it was not better than placebo, that it was probably better than no treatment, but there really wasn't a whole lot of data comparing it to no treatment, and it seemed to be equal to or better than many other practices in those areas. And so here's an example of a particular study, three-armed randomized controlled trial of acupuncture for his condition, low back pain, in which they randomized people to full-blown traditional Chinese acupuncture, sham acupuncture, in which they put superficial needles or in non-active points where the Chinese theory said these should not work, or conservative therapy. Conservative therapy is actually the European term for the best conventional medicine you can get, guideline-based medicine, so better than what most people get in practice. And here's the results of that at 13 and 26 weeks, and you can see the traditional Chinese medicine worked much better than conservative conventional therapy, almost twice as much. Okay, it worked very well, but so did the sham. In other words, you could stick a needle almost anywhere in somebody if they came in and went through the ritual, and they would do much better than the other ritual of conventional medicine. So here I had a dilemma. I had a treatment that was probably better than no treatment, although they didn't compare it against no treatment. As good as a proven treatment, or even better than proven treatments if you consider conventional conservative therapy, but no better than its own sham. What do I do with this information? How do I go back and answer his question, which is this better than no placebo? I said, Mr. Raymond, hold on for 1 minute. I need to look a little bit into why this is going on. Now, if you look at the literature in placebo and the underlying factors that go into that, there are dozens and dozens of factors that have been studied using placebo and placebo components. In other words, inert pills manipulating the context and seeing what happens. And here's a list of some of them, such as the color of the pills, the number of pills, the location, the tone of treatment, etc. In fact, changes in all these can markedly change the outcome. And my question was, is this what's actually resulting in this 100% variation I mentioned to you before? So let's look at a couple of these. What about the color? Does the color of the pill you're giving somebody make a difference in terms of their outcome? Thoughts? Yes, it does. And in fact, drug companies know this very well. Blue capsules tend to have much better sedative and calming effect than pink or orange capsules. And so most of your antidepressants, sedatives, et cetera, are marketed in blue or purple or those types of kind. Most of your stimulants, et cetera, are marketed in yellow, pink, white, red, et cetera, because this has been shown to actually work better. Here's a study, a systematic review of 12 published studies documenting this, showing that drugs that were red, yellow, and orange were associated with a stimulant effect, while blue and green were related to a tranquilizing effect. So, I better be careful, right? This works really well most places in the world, except in Italy. Curious. Some enterprising young anthropologists wanted to figure out why. So he went to Italy, and he started asking people, well, what do you think about when you think about blue? Or what do you think about when you think about red and yellow? And what he discovered was very interesting. When he asked women in Italy, the first thing they thought of when they thought of blue, what do you think they said? It's a Catholic country, that's a hint. It's the color of the Virgin Mary. Okay? Most of the images, depictions of the Virgin Mary, she's actually dressed in blue or has blue color. That's what the majority of them said. When he asked the men what they associated blue with, what do you think they said? Exactly, it's the color of the national soccer team. Okay? Stimulating, exciting, etc. They didn't get the same reaction from blue as the women can. You mixed them all together, it didn't work in Italy. It was the meaning behind the color, culturally framed, that produced the effect. What about the number of tablets? Does it matter if you give 1, 2, 4 tablets? We're all trying to get patients to take less, right? That's why we do the 1 a day instead of the 4 a day. It improves what? Compliance, right? We get more drugs in there, okay? But do we consider this? Here's a study showing that for treating ulcers with H2 blockers, if you take a tablet 4 times a day, you get significantly more healing rates of the ulcers than if you take it 2 times a day. These are the placebo arms, by the way, so this is just taking the pill. In fact, the number needed to treat if you go from 4 to 2 is 12, which means you have to treat 12 more patients with 2 tablets in order to get the same healing effect from telling them to take 4 tablets. Okay? When we're trying to reduce the number of tablets, we don't take this into consideration, do we? What about the label on the packet? How many here have had patients that come to you and have said, Doc, man, you gave me this generic drug and it just doesn't work. I want the real stuff, right? Does that happen to you? Well, of course. And it's true. It doesn't work. Here's a study looking at how we label a medication for headaches. In this case, it was aspirin. It was 4-armed. The unbranded placebo is just the act of taking a pill, and this was the effect size in terms of the difference in terms of their pain scale. And as you can see, taking a pill works. We've already showed that. More pills seem to be better up to a point, right? If you branded it then something, very strong like Bayer aspirin, then that worked in the gray components right there. If you actually put aspirin in it, it actually worked pretty well too. Aspirin does work for headaches, but of course the biggest effect was taking a pill, putting aspirin in it, and then branding it Bayer. This is why your generic drugs don't work as well. What about how we deliver it? Whether it comes through a pill or injection, or whether you do it at home or in the hospital. There's a big trend. I used to do home visits all the time. Then they went away, and now I guess they're coming back, right, to do home visits. Does it make a difference where you actually deliver the treatment? Yes, it does, in fact. If you give a placebo as a pain medication through a pill or an injection, the pill will almost always work better. I mean, the injection will almost always work better. People believe that injections are more powerful. If you have the treatment in the hospital, a therapeutic setting, a house of healing, it will work better than if you go and deliver it within the home. Think about next time you make a home visit. What about the tone of the way you deliver your treatments? Does that make a difference? Makes a big difference. This is one of my favorite studies. It's an old study, but it was still a very large randomized controlled trial done in England, in which the title of the study was, "Is there any point to being positive?" And what they did is that they took several hundred surgeries or clinics in England, and patients that came in that had functional problems, that didn't have a specific organic treatment requirement, which is about what % of patients that walks into a primary care's office. Anybody know? More than half, actually. About 60% of what walks into your office is functional, it's symptomatic treatment. So they took those patients and they put them in a study where they randomized them to 2 different messages. So this was a scripted message that the physicians had to go through. On one hand, they said that the message was a positive message, Well, I don't think what you have is very serious. I think it's going to improve. I want you to take this pill, and if it doesn't get any better, give me a call, and we'll figure it out. The other half were given a message, took the exact same amount of time, okay, which is, well, I don't know what you have. I'm not sure what will happen to it. You can try this if you want. If you have any more problems, give me a call, okay? A positive versus a neutral or a negative message. Then they had blind follow-ups a month later where the patients were called and said, how's your problem? Do you need any more? Have you needed any more treatment, et cetera, et cetera? And over 60% who got the positive message said, no, I'm doing fine. I didn't need to come back in. It improved quite a bit, versus less than 40% who got the negative message in the exact same amount of time it took in the visit. Highly clinically and highly statistically significant. Now, cognitive psychologists have known what's going on for years. Hypnotists, for example, and others have shown that suggestion will color perception and biological response. If you show a person a blue flower and under a suggestive environment like hypnosis, you tell them it's, a yellow flower, and you tell them it's a blue flower, they will report and swear that it's a blue flower. This leads to the first mechanism underlying the meaning and context effect, which is expectancy and expectation. And if you look at the list of conditions that have been shown to improve by expectancy, it looks very much like the placebo list. It looks very much like the effects of integrative and complementary medicine. It looks very much like the effects of what we do in conventional medicine in terms of what gets better. This applies to Mr. Raymond, by the way, too, because if you look at the acupuncture studies, almost no matter how you ask about expectancy, those who come in with a higher expectancy to get acupuncture will get better at a much faster rate. This is a study by Klaus Linde from Germany, who demonstrated that expectancy impacts acupuncture benefits across the board. So the belief of the patient makes a difference. We've illustrated that. But what about your belief? Does it matter what you're thinking about inside your own head? That you think something works or doesn't work? Do you think? Does it matter indirectly or directly? Or both? Here's one of my favorite studies. It was repeated by Richard Gracely from the NIH. This was done to look at the effect of practitioner expectations on patient outcomes of pain. And what he did is that these were all young people getting their wisdom teeth removed, very common post-operative type of pain scenario. And so they're measuring the pain afterwards. And they went to the oral surgeons in this case, and they said, okay, your patients are either going to receive placebo, naloxone, or fentanyl, or they're going to receive, or they went to the other group and said they're either going to receive placebo or naloxone. Now, placebo or naloxone should either have no effect or make the pain worse. The only painkiller in the regimen was fentanyl. And so they told one group of physicians they might get fentanyl. The other group, their patients would not get fentanyl. And then they said, oh, by the way, this is a study on your expectancy, not on your patients, so don't communicate to your patients that they're in a study. Now, I don't know how they got that through the ethical committee, but I'll leave that to them. Then they measured the pain outcomes on the patients afterwards, so no verbal communication about what was going on. Those physicians that thought their patients could get a painkiller, the patients reported significantly less pain than those who thought their patients weren't going to get a painkiller. They all got placebo. Okay? It was what the physician held inside, their own expectancy, that had a large effect on the pain reported by the patients. What about the information provided to the patient as they go into a clinical trial? This is called informed consent, or they go into a procedure, right? You have to give them informed consent. Does it matter the information that we give them in those areas? Yes, it does. Here's a study in which cancer patients were given a painkiller or given a placebo with or without informed consent. In other words, they were told they were in a trial and they might get a painkiller, or they weren't told that. And from this study, you can see that the best pain relief was from naproxen, the painkiller, along with consent. The next best relief was from the placebo, along with consent. The next one was naproxen without information, and the worst was the placebo without information. The placebo with information worked better than the naproxen without information. We actually have begun to dig up the underlying neurological impact of this and how this works in the brain. How does expectancy modulate pain? Here's a series of studies done in which they've looked at an experimental pain and then a painkiller that's used to reduce that threshold. This is baseline right here. Then they deliver it with expectancy, no expectancy, or a negative expectancy. And what this is this is going to work, the positive expectancy. No expectancy, they don't tell them anything. They do get some pain relief, as you can see there. It works through particular aspects of the brain I won't go into now because of time. If they give a positive expectancy, then it enhances those effects because it actually turns on different areas of the brain. If they give a negative expectancy, there on the last part of the graph, they can completely reverse the effect of the painkiller. That works by activating areas in the hippocampus that turn on anxiety and other factors that increase the pain in those areas. So you can completely enhance or completely negate the effect of your treatment simply by the message that you deliver when you give that treatment. This is what I was taught to tell patients before I did a procedure, right? This is going to hurt. A little. And then when it did hurt a little, what did I do? Okay? It'll be okay. I reassured them, okay? It'll go away. It'll be okay. Okay? I was taught to inform them that it was going to hurt, and then I was taught to reassure them. Is this the right thing to do? It's the exact wrong thing to do. Here's a study in pain actually showing that when you deliver an expectancy that this is going to hurt, you're actually delivering a nocebo effect. And if a person is told this is going to hurt before they actually get stuck or the procedure is done, they will report higher amounts of pain and discomfort than if they report that something is going to happen, but they're not led to believe that it may hurt or may not hurt. If you then reassure them, they will report higher levels of anxiety. The thing that I was taught, and that I did hundreds and hundreds and thousands of times over my career, was actually creating more suffering than it was alleviating it. Let me show you a couple rituals that put these things together every day in our practice. Here's ritual 1. This is post-operative analgesics or morphine. In this case, it was metronidazole. And it's done in an open way or it's done with a ritual. So the typical ritual that was done, the patient says, I need a painkiller. The nurse comes in, and the full ritual is that they draw it up in the bottle, right? Okay, and they tap it, and they squirt a little bit out, and they said, okay, I'm giving you the painkiller right now, right in front of the patient's eyes, and then you should be feeling better. Okay, great ritual. So when they did that on the top, you'll see this open injection. Okay, the nurse comes in, gives the injection. This is the patient every 5 minutes reporting their pain levels, significant drop off over several hours, begins to come back up. They compared that with a hidden pump in which the patient got an injection of the actual painkiller without the ritual. So nobody came in, there was no communication, no delivery, and the pump delivered it. And here we go, there's the pump delivered without the ritual, patient every 5 minutes, no drop off in pain in those areas. And this has been now repeated multiple times with controlled experiments showing that the ritual of giving morphine for pain produces probably about 90% of the effect. Here's another therapeutic ritual, and this applies to Mr. Raymond because it has to do with how I'm going to advise him on his acupuncture request or not. This is by Ted Kapchuk, and he was treating individuals with irritable bowel syndrome with acupuncture. And he gave them 3 different types. He randomized them to 3 different groups. One is that they were just put on a waiting list, so they weren't given any intervention. 2, they were given acupuncture in a very superficial way. Come in, very little interaction, I'm going to stick the needles in, come back, goodbye. The third one was with a significant ritual. So the chief of gastroenterology comes in, says, we've got this great treatment, it's going to help you, etc. They go through and take the pulses, the arms, they give the treatment, and then ask how they're feeling, ask about their expectancy, say it's going to improve, etc. So an enhanced therapy. All the points selected, by the way, were the ones that the Chinese practitioners said would not work. So this was sham acupuncture. And as you can see, this is global improvement, this is adequate pain relief, this is symptom severity and quality of life. Let's take adequate pain relief, a dose response based on the ritual. In other words, the better and the more enhanced ritual, the more effective the impact was. Ritual number 3, the king of all rituals in conventional medicine, surgery. Now, you know what patients go through when they have to undergo surgery. It's a very prolonged process. It's in the hospital. They get met by a number of people who tell them various things, usually in anticipation that this is going to help you. People get dressed up in these funny costumes and they go into a special room and you literally put your life in their hands. You get killed under anesthesia, right? You're brought back to life, you get cut, and the knowledgeable, skillful, powerful surgeon does an intervention. This has all the elements of a meaning and context effects that ought to have really big placebo effects. Does it? Have we studied it? How much of those effects are actually due to the ritual as opposed to the billions and billions of dollars we spend on doing the procedures and the techniques? Well, the only way you can detect this is if you actually do a randomized controlled trial comparing it to the sham. You have to set up a sham surgery and make it convincing enough for everybody that you're doing the surgery without actually doing what you think you're doing, right? Well, as it turns out, there's been several of those kinds of studies done, especially for pain. One of the first ones was done back in the 60s. It was called Bilateral Internal Mammary Artery Ligation. I will only say that once, BMAL. This was before we had bypass, heart-lung bypass, and it was used for coronary artery disease because you didn't have to go in and actually do a revascularization. What they did is that they exposed the mammary artery underneath the pectoral area, and they tied it off, they ligated it, and then they closed the person back up. The idea was that there would then be retrograde flow into the heart that would increase circulation and they would get relief from angina, and it worked. Very common procedure that was done all over the world in the 50s and the 60s. It was standard of care. Then somebody went into the lab and, apologies to Mimi, did a dog study. And measured the coronary artery flow and showed there was no retrograde flow. So the theory couldn't be right. So then they followed up with 2 studies in which they went through the whole ritual of internal mammary ligation, but they didn't ligate. Patients were taken into the operating room, the artery was exposed. They said, "Hi, little artery." They did not open it up, okay? Half of them they ligated, half of them they didn't ligate, and this is what they found. In fact, the sham worked just as well, in some cases better, in relieving angina and even in functional aspects. What happened to this procedure after these 2 studies? Gone, right? It's not that they didn't work. It just didn't work according to what we wanted them to work like, right? Gone. The other thing that happened is that they invented the heart-lung bypass machine, and so we started doing what? Cabbage, right? Coronary artery bypass. There has never been a sham coronary artery bypass study. I don't think there will be. What is the percent relief of angina from coronary artery bypass on average? Anybody know on average? People go in, they get bypass surgery. What percent of them now have their chest pain relieved? After the heals, of course. It's about 70 to 80%. Exact same percentage that the sham BMAL studies produced. Here's a newer one, percutaneous laser direct myocardial revascularization. I will also not say that one more than once. This one's really fancy. You don't need to open the patient up, and this is primarily for patients with congestive heart failure that are really not candidates for bypass. They thread a catheter in, has a laser on the tip, they put it right up against the myocardium, and they poke holes in the myocardium with the laser. idea is that it increases circulation into the myocardium. Good idea. Works quite well, actually. People get about 80% relief of their angina from these areas. And then somebody did a placebo study, and in anticipation of that, Alan Johnson, in a prescient article in The Lancet called Surgery as Placebo, said electrical machines have great appeal to patients and I think doctors, and recently anything with the word laser attached to it has caught the imagination. We like lasers. They work, right? So here's the results of a randomized sham-controlled study with this procedure. All these individuals had class 3 or 4 congestive heart failure, and they randomized them to either get the full hole poking, minimal hole poking, in other words, they threaded it up and they turned it on, poked half the holes, or no hole poking. They threaded the catheter up, put it against the myocardium, and the machine was never turned on. 3 months and 6 months later, the angina and the functional class had significantly reduced, and that lasted for over 6 months, including in the sham group. Here's another one, arthroscopic surgery for arthritis. Many of you may have seen this. It was published in the New England Journal of Medicine a number of years ago. This was for debridement and lavage of individuals with osteoarthritis using laparoscopic procedures. The thought was, is this any good? We know that people get pain relief from this. It's been reported. It's standard of care. And here's a study done showing that if you simply put the scope in, put a little water in there, and pull it out, or if you go through the entire surgical procedure and make a little cut, don't even put a scope in, but they think they've had the arthroscopic procedure, they'll get significant pain relief, in fact, at the same rate as if you do the full debridement with that. Now, lest people think we can distinguish between active and placebo because placebo only lasts for a little while, this one was followed up for 2 years with equal continued pain relief in all groups the same. That's another myth. Here's a newer one, vertebroplasty for osteoporotic spinal fractures, and I won't go into the details of this one. 2 large studies published showing that you don't have to put the cement or the balloon in, which is what this procedure is, where you stick in and you try to expand the vertebral space. All you have to do is take them into the operating room, act as if you're doing the placebo, do a little topical anesthesia, local anesthesia, make a bunch of noises in the emergency room, and they will get the same pain relief when they come out as if you had done the full vertebroplasty by almost any measure. We just completed a meta-analysis of all pain studies in which there was an interventional procedure, surgery, or an endoscope or arthroscope for pain in a variety of areas, low back pain, arthritis, angina, and migraine, collecting all of the sham randomized controlled trials that were available. And here's what we found. The effect sizes in all of these was 0 to none, in some cases negative. The p-values were negative. The migraine, actually, p-value was positively significant, but that was because there was only 2 studies, one large one that had an unusual procedure in which they perceived a very large effect size in the active group. It doesn't appear that surgery or interventional procedures for pain and chronic pain actually work. But they do work. They work because our culture believes that they work. So we've talked a little bit about the expectancy. We've talked a little bit about the factors that influence that. We've talked about the communication between the physician and the patient. But what about this soup bowl that we swim in? What about the culture? Does that make a difference? Does it matter which culture they're in? I've given you a hint of that with Italy, but there's actually significant information now on the impact of the culture. Here's a fellow who has been blessed by a sheikh and been told, God will protect you from pain and bleeding. Go forth and demonstrate this. So he comes into the laboratory, we hook him up with EEG, and he takes a barbecue unsterile skewer and he sticks it through his cheek all the way through. and we're monitoring his EEG, and yes, does it show up in his EEG? Yes, the sensation part, but the pain, anxiety, the amygdala hippocampal areas, much, much lower than if you were to do it to you and I. He's able to control this, pull it out, never seen an infection, very minimal bleeding after this. Here's more data on that, okay? In Chinese culture, there is a great belief in traditional Chinese culture that particular years are associated with particular problems that you're going to die of. So if you're born in an earth year, for example, right here, you're going to have lymph and spleen problems. If you were born in a metal year, you're going to have lung problems because you have low energy in those areas. And indeed, if you look epidemiologically across the death rates of Chinese citizens, you'll find those who were born in Earth years die significantly earlier of lymphatic cancer than those who were not, and those who were born in metal years die significantly earlier from lung diseases than those who are not. And this phenomena disappears as the culture, you get farther and farther away from traditional Chinese culture as you move over to the US or Hawaii, as the generations move away from these areas. So it's embedded in the culture itself. Well, we don't believe in Chinese astrology in the US, but what do we believe in? What does our culture really value? Money, you bet. Does money make a difference? Does how much money attached to an intervention make a difference in terms of how well it works? Yes, it does. Here's a study published in JAMA showing that you can alter the pain threshold. In other words, how much pain an individual can stand if you give them a more expensive painkiller than if you give them the same painkiller at a discount. So here's the same painkiller. This was placebo, by the way. And you were given the full-blown, this is a new generic drug, the latest, et cetera. It's going to cost you X, Y, or you're going to get it at a discount. If you get the full-blown cost, you have much better pain relief and increased your pain threshold. We believe in money. Here's Dan Moorman's study showing the impact of this. And this is one of the most, I think, important studies on placebo ever done. It was an anthropological study. What he did is he collected 117 studies of the treatment of ulcers. Now, these studies were done back when H2 blockers first came out. Now, for those of you that are my age, you remember pre-H2 blockers, how did we treat ulcers? You know, chalk and antacids and stuff like that. It was miserable. So when the H2 blockers came out, and all you had to do was take a pill, and you could cure ulcers, it was a miracle. And it was patented, by the way, and the FDA was going to approve it, and the drug companies wanted to approve it in all the countries. So they invested hundreds and millions of dollars, billions of dollars into this. And they did these studies all around the world, and they did them in exactly the same way. Put down an endoscope to objectively show that you have an ulcer, go on an H2 blocker, 4 weeks later, put the scope down and show that it's gone away. So they wanted an objective assessment. All randomized to a placebo arm or the H2 blocker arm. And this is the placebo arms of those 117 trials. And as you can see, it goes from 0% healing, this little study down here, all the way up to 100% healing of the ulcers in the studies. Now, when Dan divided this among countries to look at the placebo healing rates, he found there were marked differences. Very high placebo healing rates for ulcers in Germany, 60%. In fact, they did 5 studies there, could never prove that it worked. In other words, could never prove the H2 blockers worked because the placebo healing rates and the drug healing rates were about the same. Couldn't statistically prove it. So the Germans, I guess, didn't want to pay for it. I don't know. In the Netherlands, right next door, markedly lower placebo healing rates, 3 studies, very easy to prove that it worked. And in Brazil, which we now know may have had other causes for their ulcers, very easy to prove that it healed. In fact, the rate of placebo healing in the arms was the most important determinant factor whether you could scientifically prove it or not. Not whether the drug worked. The drug worked the same. This variation in culture functionally related to the drug effects. In other words, the more effective the drug, the more effective the placebo. Here's a meta-analysis of studies, again, from the ulcer aspects. Oh, and by the way, it isn't that just Germans are good placebo responders. The blood pressure studies don't show this with Germans. They actually have very low blood pressure placebo response rates. The variation effects is affected as new treatments come across. In other words, if there's two competing treatments, you'll see differences in effect. How many of you have heard the adage, use a new drug as much as you can when it first comes out before it loses its effectiveness? This is something I was told by my mentor. Well, this is actually true. So here's Cimetidine. This is a meta-analysis. The line shows the average healing rates of Cimetidine in the ulcer studies from 1974 to 1990. And then the competitor comes along, Ranitidine. And Ranitidine was the latest, it's better. Blasted advertisements. The culture was inundated with, this is the new and the latest drug. Patients were coming in and saying, yeah, I've been on this one, shouldn't I be on Ranitidine? This is the controlled study of healing effect size, and as you can see, when it first started, Cimetidine, the healing rates were about 80%. When Ranitidine came along and they started to do the studies on Ranitidine, it picked up at about that, 75 to 80%. And in the controlled studies, including the placebo arms, the effect size of the Cimetidine studies, which were still going on, precipitously dropped. In other words, it stopped working. This variation is affected by changes as attitudes and the cultural expectancies change. Here's a 20-year trend of the rates of placebo, the rates of depression improvement in any study from depression with a drug and a placebo arm. The yellow and the green lines are the tricyclics and the SSRIs. The red line is the placebo. And from 1980 to 2000, there's a steady increase in responsiveness, no matter what. This has caused a dilemma among drug companies because now they don't want to develop a new drug for depression because it's very difficult now compared to back in the 1980s to actually demonstrate that it works because the placebo rates have changed in the culture. All right, well, what's underlying all of this effect? We're beginning to dig out the mechanisms of this. I've talked to you a little bit about the expectancy. And we know now that has a major mechanism. In fact, we're beginning to look at the biology of expectancy. Expectancy can manipulate opioid receptors, cortical descending pathways, dopamine release, for example, have all been demonstrated. Another mechanism is social observational learning within the context, and I've illustrated some of that. Ritual, suggestion, stress reduction, motivational frames, etc., and the belief component. The educational components that Mimi talked about today, and the observational components. There's another one called behavioral conditioning that is just emerging and may be the most powerful mechanism of all underlying meaning and context effects that you incorporate in your practice every single day. And that is the modulation of a combination of expectancy or expectation and conditioning, repetition, using a conditioned stimulus. This comes from the classical conditioning understanding from Pavlov's dogs and bells. You remember in his classic study, he showed that he could ring a bell, feed a dog, they would salivate, and after a few associations of that, all he had to do was ring the bell and they would salivate. That's a physiological effect from a conditioned stimulus. Well, this happens in our body too. And this was happening with Mr. Raymond as he came in every time and said, gee, is this thing going to work? And it didn't work. He was conditioned to it not working. Here's a study showing that in humans in an immunological aspect. What they do is they give cyclosporin A, a significant immune suppressor, and then they give a placebo drink, usually a red drink that's sweet and has a lot of olfactory components to it as a conditioned response. And they do that 4 times over 3 days, and then they assay the immune suppression. And then they have a little gap, 5 days. The patients come back, and then they're just given the drink, and that's all. And here is the IL-2 and the interferon gamma rates. When you give cyclosporin A, you markedly suppress interferon gamma and IL-2. If you just draw their blood, they don't have it normally suppressed. You just give the drink, then 8 days later, almost an equal suppression of immune response. So what you do, and the ritual you do, if you simply repeat the ritual without the drug, and they've been conditioned, can produce significant effects. In fact, ferreting out these mechanisms I find extremely interesting. For example, expectancy, at least in pain areas, seems to work through our own endogenous opioid system, and you can block that with drugs like naloxone, which are receptor blockers. However, if you use conditioning to improve pain, in other words, if you were to give a pill, it depends upon the mechanism of the pill as to what the conditioning actually produces. So your body learns from the pill what to do. So for example, if you use opioid conditioning, you give morphine and then you do conditioning and then you remove the morphine and you just give the stimulus, you can reverse that with naloxone. It's using the opioid pathway. If you get non-steroidals or some other kind of pain medication that does not work through that pathway, you cannot reverse that through naloxone. It's using a different pathway. Your body is learning the specific mechanisms in these areas. Recent studies by Carol Meissers from University of Munich is now beginning to show that you can condition people to get specific organ responses and not other organ responses. You can have an effect on the GI system, for example, but not the lungs. You can have an effect on the lungs and not the GI system, depending upon the message that you deliver when you give the treatment. In summary, then, I'll say the context and the meaning of medical encounters can have a dramatic effect on outcome, that people, the patient, the doctor, and the culture, what they know dramatically affects the outcomes, and therefore the same medical intervention, active, proven or not, can have very different effects in different settings, attitudes, and cultures. These differences can be positive or negative, and they can be very clinically significant. I think I found why everything works and yet nothing works. Now, what does this mean for practice? Is it ethical to actually begin to use placebo and put it into your practice? Is it ethical not to? Well, physicians already use placebo in their practice. How many here use some type of placebo in their practice? Okay? How many here will not admit it? Doctors don't admit it. When I was in medical school, I could actually write a prescription called Oldacap, placebo spelled backwards, and the patient could take it to the pharmacy and they would get a sugar pill. Did any of you have that? Okay, yeah, a few, all right. I can't do that anymore. It's considered unethical, it's deceptive, right? So what do physicians do now? They can't give sugar pills. They've got, 5 minutes, the person's demanding a treatment. You know that there's no specific treatment or no treatment might be better. What do? You give something else, right? And here's a survey done by John Tilbert at the Mayo Clinic showing that physicians frequently prescribe not saline and sugar pills so much, which is down here, but other things like antibiotics, sedatives, vitamins, over-the-counter analgesics. In fact, more than 50% of physicians will routinely prescribe something that has no evidence that it has a specific effect. An antibiotic can have an adverse effect. So, what should we do with this dilemma? We use it in practice routinely. However, to use placebo, if in a deceptive way, is inherently unethical and therefore should be avoided. And yet, what about other dilemmas in which we don't exactly tell the patient the truth, such as lying for the patient's good, explaining that it'll work, or in the context of a trusting doctor-patient relationship? If we redefine this and say we don't have to do this deceptively, but in fact realize that this is coming from us and our behavior within the context, our relationship with the relationship with the patient and with the context of the culture, that it is evidence-based and it is a powerful modality, then we have an ethical responsibility to use it and to understand it. Mr. Raymond. Well, he's been sitting in the waiting room a long time. They're looking for this advice. Well, now I think I might know how to answer his question. If I put on my evidence-based medicine hat, I'll say, Mr. Raymond, don't bother with acupuncture. It's just a placebo. If I put on my basic science hat, when I look at the mechanisms underlying it, I'll say, absolutely use it. Not only does it work, but we know how it works in the brain. If I put on my regulatory hat, where he's saying, well, will you pay for it now, or will it be paid for? I'll say, no, the evidence isn't good enough, right? If I put on my physician hat, I'll say, yes, I think you should use it, but I need to be very careful that the conditions and the process and the delivery and the follow-up that I do with that. If I put on my skeptic hat, I'll say, nah, the evidence shows that we shouldn't use it. If I put on my believer hat, I'll say, of course, the evidence shows we should use it because I interpret the data with different meaning. So how do we create a practice that takes this information and actually maximizes this in our own practice? Here's a list of things, and these should be in your slides, that have been shown from research literature to enhance healing from placebo studies. Use more frequent dosing. Apply therapies in a therapeutic setting. Attend to the route of administration. Deliver them with confidence in a warm and caring way. Check to see what your patient believes in and wants. Check to see what you believe in and want. Check to see if those beliefs align. I didn't show you that data, but the congruence of beliefs has a significant impact on outcome. Deliver a benign but frequent conditioned stimulus along the way. Use the newest and most prominent treatment available. Use a well-known brand name identified with success and make sure it costs enough. Cut, stick, poke the skin or an orifice when that is believed to be important. Inform the patient what they can expect, but be careful how you do it. Use a laser, a light, or electronic device to deliver and track it. We've seen a lot of those. Incorporate reassurance, relaxation, suggestion, and anxiety reduction methods. Listen and provide empathy and understanding. Touch the patient. At the Samuel Institute, we've tried to organize these into a systematic, structured way that this can be brought into practice. We call it an optimal healing environment. And we use techniques to both measure and deliver things that are in the internal environment, as I've indicated, managing expectation, hope, understanding, belief, personal experiences of wholeness, such as mind-body practices, the interpersonal environment, the dynamic around communication, compassion, support, and social support and empathy, and embedding that in the culture in which we live through leadership, mission, teamwork, and technology. And then we go to the behavioral environment, the things that you hear about so much, the diet, exercise, relaxation, etc., and the integrative, person-centered care, family-centered care, culturally centered aspects. And then finally, pay attention to the external environment, the physical characteristics of where the practice is. Is it facilitating healing, or is it detracting from all the other aspects of this? So I'd like to end with a poem. It's called Proof of Healing. What shall we do with the healing ones, those open faces without memories, the fleeting dreams of the day sleepers? They see clearly without a theory, a long pause, a deep breath, and a short insight. It's always too soon for the healing ones, when the talking docs start with streams of opinion, fixing a premature future by oozing data from every perception. Somewhere, a grandmother lives fine with cancer. A child receives kindness through her IV. A father gives away his most precious hope for another. What shall we do with the healing ones in the face of proof? Thank you.